Good day. This is Charles Denham, and we want to welcome you to our 105th sequential monthly webinar, part 3 of our Sepsis series, Bringing It All Together. And we're delighted to have you come. I'm Charles Denham, chairman of TMIT, and I am on our second slide. The third slide, for those of you that are following along in the slides, just make sure that your WebEx volume is to the max and your computer volume and external volume are all the way up in case you're having any audio difficulties. And if you are, I'm on slide 4. If you're having audio difficulties, click on Participants on the icon, and in the lower left-hand corner of your screen, you'll see a question mark with a phone, and if you click on that icon, we can give you a direct line that can help you. Then on slide 5, those of you that do not have the slides yet, please go to www.safetyleaders.org. When you get to the landing page, look at the upper right-hand quadrant on upcoming events, and if you'll see this webinar there, and click on that, and that will take you to the page where you can download the slides, and others can register, and you can come back, and I think there'll be numerous resources that we'll probably post after the webinar, and you'll be able to come back and watch the webinar and listen to the audio and be able to view the slides there. I'm on slide 7, and their social media addresses are there for you if you would like them. And our TMIT purpose statement on slide 8, just to remind everyone that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And we like to say that everyone can be a caregiver, especially now that we're focused on bystander care and patient safety as well. So our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. And we are very pleased to be focused on this topic of sepsis today and have Dr. Huddleston come back to tie it together with the mortality reviews. Slide 9, our disclosure statement, and there are no products, services, or technologies that the speakers will be referring to and have no financial or conflicts of interest with those. And so we have Dr. Jeanne Huddleston will be our main speaker. We have Jennifer Dingman as our patient advocate, and I'm going to be coordinating the presentations and also give you an update on the news and our polling. Before we get started, however, I'd like to ask Jennifer Dingman, who's representing the voice of the patient, to speak for a moment. Jennifer is the founder of Pulse, the Persons United Limiting Substandards and Errors in Healthcare. We've worked with Jennifer for a long time. She's actually, as a published author in patient safety, a contributor to the NQF Safe Practices, and she served on numerous committees with the government in patient safety and quality, and also been just a steadfast champion for patient safety. And it was some of her work, along with the group that meet on a regular basis, that helped get the hacks through, the hospital-acquired conditions work through, and so many of you have participated in those and done a great job on those. So, Jennifer, would you please start us off with the voice of the patient and keep us grounded in what we're to do today?
Thank you so much for your kind introduction, Dr. Denham. I just want to let everyone know what an honor it is for me to be here today. And I am so thankful for these webinars because they're saving so many lives. And I just want everyone here listening today to know how much it means to myself, my colleagues, and our families that you care enough about your patients to be on these webinars. Today is going to be fascinating and interesting, and Dr. Huddleston is just fantastic in everything that she says. She's such a great leader in our cause of making healthcare safer for all. I just want you to all know how grateful we are for you to be here today. Please share this widely on the recordings with your colleagues. Invite people to come to future webinars. And just thank you again. You're all a very large blessing in my life. I'll turn it back over to you, Dr. Denham.
Thank you, Jennifer. And Jennifer is one of the wonderful contributors of a number of advocates who have had patient safety incidents or adverse events in their families and have turned that into the positive, and they meet every other week, focused on numerous, not only national but global objectives. And so thank you very much, Jennifer, for your contribution. And so now I am going to briefly go through some of what has been in the news and the national survey highlights from last month. So our anonymous questions that we ask you, in order to help us drive the decisions on what we do in our future webinars, we ask these questions in order to get guidance from you. And the topics that we cover are basically decided by you. So we ask, are you more interested in opioid-related best practices? And a whopping 69% of you gave it a 10 on a Net Promoter Scale basis. That's enormous. And so, yes, we will, and it may even be the next webinar because of this crisis we're seeing with fentanyl and carfentanil, and actually drug diversion, and a number of things that are happening in our workforce as well as our patient base. I won't read the bullets of this slide because I'd like to move on to Dr. Huddleston, but you'll see that you've given us a pretty good menu of things that you would like to see regarding opioid overdoses, alternative therapies, drug diversion, what can be done with the school systems, what can be done in your community, prescribing laws, accidental overdose in ED personnel, and especially with fentanyl and carfentanil being by volume so powerful, and now we're seeing first responders suffering respiratory arrest, and some of them being refractory to Narcan because there are two strains now of fentanyl that are refractory to Narcan. And Narcan you can have so much in the system that the Narcan could work and then they can relapse even before you get them to somewhere to where you can manage the airway. So this is an evolving area, and you've given us a nice menu, and I'm going to the second slide, slide 15. Again, I won't belabor the process. You can go ahead and read these. We're taking to heart what you've said and what you've told us, and if you have any opioid suggestions on the other free text entry later in our presentation when we poll you, drop them in. We'll understand that you're answering the opioid question, even though we may be asking other questions. We have three questions that we'll be polling, and then three open text entry questions in order to guide our future webinars. We ask you, are you interested in more detail on caregiver drug diversion? And again, a super high number at 54% of you gave it a 10, 18% gave it a 9. So we've got 84% agreeing and 72% strongly agreeing. So you've spoken. Yes, we will. We will cover drug diversion. We'll try to get speakers that actually have had successful programs in some case studies that can help you. And you also gave us a menu of items regarding the drug diversion. And you could see some of the topics about back pain, more training regarding providers on pain management, best step methods of detection, monitoring methods, lockup recommendations, really practical insights you've given us. So we're so grateful for you all to respond, and we will address all of these in that webinar that we'll cover. So we've been reintroducing periodically this MedTech program that we've been developing with leaders from the MD Anderson, Mayo Clinic, Stanford, UCSF, and a number of really great frontline leaders regarding the leading causes of death and harm to kids, college students, and workforce. It turns out that the numbers of each one of these high-impact care hazards change. You have much more opioid overdose and alcohol poisoning in college students than you would in children 5 to 15, yet choking and drowning and drive-over accidents are very high in the lower end, and major trauma actually is pretty high in all the areas. So we've been working on this program. We've graduated 3 classes in after-school and summer school programs, and in September at Texas Medical Center we'll be launching the first full comprehensive program for police and first responders from security. So they'll get gunshot wounds and a whole host of other topics that you wouldn't teach in a school. All of them, though, are focused on slide 19 in bystander care, which is technically the first 10 minutes before the first responders arrive. You may be in an urban area where there are 5-minute response time. generally, the first responders are the police because they have faster cars and it can negotiate the traffic better. And it's important that people realize that not only is it the first golden 10 minutes, but it's also the pre-hospital EMS care and supporting the families, getting drugs, getting the medicines, medical histories of people that can then be used in the emergency department, and then the definitive care through the emergency department. So the MedTech program is focused on that continuum. Before first responders arrive, which is 8 to 12 minutes, the pre-hospital EMS care and supporting families along the transport, and then the definitive care in the ED. And we have Dr. Toph Peabody at UCSF is taking the lead on the emergency care. Last month, we put up the 5 rights of pain care, which we had developed in the last 5 years, working very closely with Dr. Gladstone McDowell and focusing on proper pain care to get out of the short-term opioids, prescriptions, and actually take an integrated approach to the right test, right diagnosis, right treatment, right monitoring, and right prevention. We won't belabor it today because we'll move to Dr. Huddleston, but this will be part of the opioid work that we'll cover. And for those of you that missed the opioid webinar that we did last month, please go back to our website and watch it. This is an absolute crisis, and you can see on this slide, slide 21, by volume, the comparative overdose, the amount of substances necessary to overdose a patient in heroin, fentanyl, and carfentanil. So carfentanil, 10,000 times the potency of morphine. Fentanyl is 1,000 times. And so, and we're seeing that the synthetics, which are fentanyl and carfentanil, that are being developed in offshore laboratories and brought into America, are the culprit of a number of these overdoses. So in the news, this topic is really picking up speed. This is a head of print article regarding the critical crisis of opioid overdoses, and this is just in the last month. And the preparation of the ICUs. We know that an enormous number of ICU admissions for this. And in Ohio, the morgues are so full they need they need refrigerator trucks to hold the bodies because they have just no room. So we're seeing the data in this. Now, this is a WebMD article. We thought it was pretty interesting. I'd go back to the sources they use, not that we're saying that the WebMD is comparable to the New England Journal of Medicine, but if you go out on the web, you'll see some of the numbers that are enormous and this explosive growth, which we've addressed over and over again. It's interesting to see the cost of the ICU overdose admission in 2009 was almost $60,000, and now it's more than $90,000 in 2015, and it's a new level of crisis, and it's addressed there. The Washington Post article has further data regarding the fentanyl overdoses and how many are linked directly to fentanyl, and the rise in the Cook County of 2,700% increase in fatal fentanyl overdoses, and the number likely being 60,000 in 2016. And the number that people need to remember is that we've got over 90 deaths a day due to this problem. The Washington Post article, August 15th, here since our last webinar, showing fentanyl linked to the thousands of urban overdose deaths. And these slides, I think, might be helpful to you as you help describe this as a critical patient safety issue in the emergency department and triage in your outpatient clinics, because now we've got so many organizations that have outpatient clinics with people coming in that may have these overdoses, and knowing how to manage them and actually protect the caregivers. Getting to that, August 3rd, this news item was the accidental overdose of the law enforcement officer deputy after addressing people on drug charges. And so the recommendations are kind of evolving rapidly. Do you wear safety glasses? Do you need to gown up when your first responders are near these people? Do you wear gloves? And the answer is probably yes, yes, and yes. And there'll be more guidelines. In last month's webinar, we covered the Homeland Security recommendations in the state of Indiana, which were pretty helpful. The other problem that is evolving, though, is the fentanyl that is refractory to Narcan, and we're told by our pain doctors that this has popped up in New Jersey. Now, we also have been addressing the overdoses of marijuana and this enormous number of admissions. Colorado is probably one of our best laboratories, and we're seeing an enormous number of admissions to hospital, including symptoms of sleepiness, difficulty breathing, seizures, even coma. Kids are on life support and airway support. And there's a volume concentration relationship like there is with carfentanil. When a kid eats looks at a brownie, they think that the brownie is like a brownie that they might eat. Well, there are 4 adult doses in the typical volume of one of these edible brownies, and unfortunately, it's so easy with the concentration, of the active ingredients. It's a critical issue. I'm going to move quickly now to another topic that's just popped on the grid that you need to be aware of, and that is the acid attacks by gangs, by domestic terrorists, and by international terrorists. There are more than 1,800 acid attacks that have occurred in England and London alone. I've got a little bit more data for you. One of our colleagues we're working with on the MedTech program has done more risk assessments at schools around the world and violent intruder and active shooter assessments, and brought to our attention this week. He said, listen, you've really got to tell your audience about this. Hasn't happened yet to a degree that you'll see it in the press, but he's worried because the cost of the battery acid, it's very plentiful. It costs nothing, almost nothing to get, and it does an enormous amount of damage to people. And he believes that we're going to start to see acid attacks rolling into our emergency departments, and that we need to be prepared for it. If you, I'm on slide 29, so the MedTech program is about bystander care. And so in our opioid overdose and poisoning topical area, modular area, we will be adding this because they're really pulling the warning horn on this. The number of UK attacks have soared, and this article says there have been almost 2,000 acid attacks in London alone since 2010, and you can see the kind of numbers growing there. And so what do we need to know about those things? Well, we need to know that car battery acid is the most frequently used in the attacks. This is a patient safety and a caregiver safety issue because if you don't see the volume of them coming in, your caregivers or even into clinics that are nearby, instead of going to urgent care or the emergency department, they may roll into your outpatient clinic. And what can you do? And so here's some content regarding the ocular burns and the typical chemical substances that are either acids or alkali substances. And car battery acid is one of the most common. So the principles of management, and not that you all will be experts in this, but I think we need to at least bring it up in case there's a rash of these attacks, or we had a group that were hit, especially in urban areas, that the potency and concentration of the toxic agent is really, really important. It's critical that scene safety is absolutely critical. Protection of the rescuers and the healthcare workers, removing the patient from the exposed area, jewelry and clothing, brush off the dry chemicals, and any suitable instrument may be used. We're reminding you that this may also be in a drug bust situation, that an N95 mask and using gloves and really almost universal precautions, because the substances can damage our caregivers, and if they are drugs, and if they're a powdery substance on anybody that comes in to the emergency department, remember the opioid issue. And the most important component is irrigation of all wounds and access with copious amounts of water. Dr. Toft Peabody could not be on today, but provided this information. He's an associate professor of emergency medicine at UCSF. Final topic is we've had a huge amount of interest in coming back to patient safety, adverse events related to the EHRs, and also test result reporting and follow-up, which is an enormously growing malpractice issue. And so we reached out to our prior speakers on this. These are the ECRI, and I'm on slide 32. These are the top 10 patient safety concerns for 2017. We've highlighted information management in the EHRs and the test result reporting and follow-up, especially after the National Academy of Sciences and what we formerly called the Institute of Medicine, the National Academy of Medicine report that came out in the last couple of years on misdiagnosis. So now just to remind the viewers who are, we had over 600 pre-registrants today, and we have over 330 online today that are live. We want to remind those that are viewing this at a later date that in detail we've covered sepsis and the basics part 1 with Dr. Huddleston doing an introduction and had a terrific presentation on this topic regarding pragmatic sepsis care for providers. Dr. Huddleston is going to tie things together for us, but Dr. Ryan Arnold did an awesome job. And just want to remind you, you can go back to our May webinar series on www.safetyleaders.org, click on webinars, and then click on sepsis. His topic was sepsis for practicing physicians, to remind you. And he addressed aligning evidence, guidelines, mandates, and policy to inform your daily practice. He did a terrific job. And you saw the graphic that now Dr. Huddleston will be recapping, but the graphic regarding the spectrum, the sepsis spectrum. And I won't go into it. I'm just have this slide here just to remind you, for those of you that are watching this webinar first and maybe didn't pre-register, then our second acute care sepsis, our second part 2 on sepsis was acute care. And we had Dr. Casey Clemens do a terrific job. He also from the Mayo Clinic covered the topics. And again, I think Dr. Huddleston will address it. He addressed pragmatic sepsis care for providers and the objectives to understand the historical context, explain the Mayo model, illustrate the importance of care, and that sepsis was a final common pathway. And so that leads us up to Dr. Huddleston. We've had her on as a frequent speaker. She is just rips the cover off the ball in hitting it out of the park for us on the topics she's covered. If you go back to our prior webinars, she has introduced and then given us a deep dive detail on the mortality reviews, the more than 12,000 or 13,000 sequential mortality reviews at the Mayo Clinic, and shared enormous and valuable information to us, and has been the person that has helped us find the right people on sepsis. And we've asked Dr. Huddleston to go ahead and cover sepsis and bring it all together. She's a hospitalist. She was the one that led the work at the Mayo Clinic. She returned to get engineering degree and the real grounding and measurement that is so critical, that what our boards and what our physicians demand, and has just done an awesome job at pulling things together. And I've asked her also to address the global collaborative that she started with organizations, which is a terrific way to collaborate on mortality reviews to cover much more than sepsis and really address these opportunities for improvement that are both commission, which we all are really focused on, but also omission, which I think is the next generation of patient safety. So it's with great pleasure that I introduce Dr. Huddleston and ask her to take it away.
Well, thank you so much for the wonderful introduction and for the opportunity to be with all of you this afternoon. I had the great pleasure of knowing both Dr. Ryan Arnold and Casey Clements and the work that they've done, and partnering with Dr. Arnold in a National Science Foundation grant and actually understanding the trajectories of medical patients with sepsis in the hospital and the impact that their multiple comorbidities have on the trajectory. As a hospitalist, I get the opportunity of taking care of older people with many multiple comorbidities, and so it's been fascinating to actually look at it from a slightly different lens. And I'll share a little bit of that information as we go along in terms of what some of our early learnings have been. So my intent is to bring it all together, and as a disclosure, I want to remind all of you again that I am fundamentally biased by this work. I am absolutely passionately engaged, and because of that lens, do get a little excited sometimes and occasionally ride a very tall horse. I will attempt to stay away from that. But I sincerely believe that by investigating and understanding and evaluating our systems and processes of care, that we truly can save lives. We can improve systems, we can build effective teams, create new cultures, and just plain make a difference, which is all I ever really wanted to do. I also need to let you know that I'm the co-founder of the International Safety Learning System Research Collaborative that Dr. Denham just mentioned. It is being supported by a social benefit corporation and a nonprofit. I do not receive any remuneration or any royalties or anything from this work. It is purely voluntary. I'm going to cover a summary of the first and second sepsis webinars. They both took different angles and helped me tremendously as a clinician understand where some of my own confusion was coming from as I attempted to take care of these patients. I want to actually superimpose those webinars and that clinical and policy confusion on top of what happens when you have those and vulnerable systems and processes. And we'll go through some case examples where all of those sort of interplay and can have dire consequences for our patients and our providers. I want to give some examples of some hope in addition to not just the dire things, some QI initiatives that I've come across, some things that we've experienced and done at Mayo, and want to explain some of the common denominators that I've seen of each and every one of these quality improvement projects in sepsis that have made a difference. Finally, I'll briefly discuss the safety learning system, and we have some new updated findings, and I'll share those with you as well. Sepsis is a big problem. I Googled it today and found out there were over 15.5 million results just with the word sepsis. So we're not the only ones interested in it, and certainly not the only ones putting things out there about it. And looking at the pictures when you hit on images in Google, it was fascinating to see the sort of the spectrum of how people are thinking about it, everything from people who have dry gangrene and their fingers are falling off to the interaction of SIRS and sepsis and infection to pictures of bacteria. I found it fascinating just from a visual perspective to get a feel for what everyone thought of sepsis, not just the medical profession. Dr. Clements had pointed out to us that it is the most costly, expensive problem in healthcare in the United States. This was a table done in 2011 that showed it was almost twice as expensive as AMIs or ACS and 2.5 times as expensive as strokes. So how do we get there? So I'm going to actually talk about sepsis 2 before I talk about sepsis 1. Dr. Clements reviewed with us that 68% of the ICU patients have SIRS. I have SIRS when I climb 3 flights of stairs. It's not very specific, and as a result, only 26% of SIRS patients have sepsis, 18% progress to severe sepsis, and 4% to shock. So all of us, I mean, even in our medical floors, we're still triggering some of our nursing sepsis-related activity off SIRS, and I wonder how much extra man hours or work hours we're putting into it that could potentially be applied somewhere else because they're so often false positives. And I know we need to do it so we can catch them because early treatment is important, but as an engineer, I sort of wonder about both sides of that coin. The nomenclature of SIRS, or of sepsis, the nomenclature SIRS being the first one. This was a neat little gravestone that said that SIRS died in 2016, but I don't know about you, but our hospital is still using it in parts. Characterized by those particular vital sign abnormalities. And in version 1.0 of sepsis, we had the SIRS in it, suspected infection, then we had severe sepsis and septic shock. People were frustrated by the lack of specificity with that wonderful definition, and so some very smart researchers went out and came up with a very clear definition. And I don't know about you, but not only can I not read it because they tried to cram too much into a very small table, but there's no way I can remember all of it. And so while it may be more specific, it hits square in the area from a human factors perspective of not being usable. So it's prudent for all of us as we try to implement things and do things that we actually create things that are simple enough for humans to do in a fatigued state, which is what most of us are when we're taking care of patients in the hospital or in the clinic for that matter. And then the sepsis 3 criteria are simplified. There's no more severe or mild sepsis. It's just sepsis with an infection and an increase in the SOFA score by 2. And then shock means they have an infection and need vasopressors and a lactate greater than 2. So sepsis 3 improves risk stratification, but it compromises recognition because, again, it moves towards the less specific side. These are the sequential organ failure assessments in QSOFA, And what's impressive to me with QSOFA is that once you get to 3 of those particular things, and there's only 3 there, respiratory rate, systolic blood pressure, or Glasgow-Coma scale, altered mental status, you've got a greater than 20% risk of mortality during that illness. Mayo has taken a look at that, and this is from Dr. Casey Clements and the others who led our sepsis initiative at Mayo, and said, you know, that's all still really complicated and people are all still using really, really different things. What are our non-negotiable principles that regardless of what score we're using, we know that we're going to follow a set of guiding principles. And we tend to use that at Mayo because we know that each of our hospitals is very, very different, and you can't have a one-size-fits-all quality improvement initiative. So even for sepsis care, we have a set of guiding principles. You need to identify it early. You need to get the antibiotics there quickly. Take care of the source, control the infection, and give the IV fluids to maintain blood flow to vital organs. Those are the guiding principles that we use. So now I'll go to Sepsis 1 and briefly remind you of what Dr. Ryan Arnold said. And this is all the issues around the different definitions with all the guidelines that we have and how that impacts us. So this is the spectrum, and from a research perspective, we are using quote-unquote big data and machine learning and other computer science and design methodologies to try to actually illustrate this spectrum through time in the course of a patient's hospitalization. And this is his spectrum of acute organ dysfunction, secondary to infection, leading up to cardiovascular compromise, which is obviously shock when the patient can no longer maintain their blood pressure. CMS is something we're all forced to actually reckon with right now, and some of the difficulties in A, capturing the data, and B, reporting it when you know that it's not necessarily where the evidence-based medicine is going. So it includes the SIRS, the organ failure, and then after you've had your 30 cc's per kg of fluid when your blood pressure is less than 100 or your lactate's greater than 4, then you fall into the CMS definition of sepsis and later have the definition of septic shock. This compares to the Sepsis 3 guidelines where you use the SOFA score, and to have your sepsis definition, and then for septic shock, a vasopressor requirement with a lactate greater than 2. Much easier to remember, but again, when you overlap them, you can see what you're missing and what you're getting as a result of using one approach or the other. Those in the gray sort of rectangles, those are patients that are not captured by a particular rule. So if your goal is CMS compliance, then this is what you would be capturing, those areas in the red with the gray not caught. However, if your goal is evidence-based medicine, then you would be following Sepsis 3, and you would have more of the sepsis patients captured and fewer of the septic shock, but largely that is because fewer of the patients in the sepsis bucket would actually move into the septic shock bucket because they would have received treatment earlier while being missed by the CMS guidelines. So that was a very, very quick overview of beautiful one-hour talks that each of them gave. And as I was re-reviewing their materials, it helped me think about the things that I hold dear, which are the process and system components, and how difficult it is to design safe processes and systems when you have a moving target of clinical definitions and policies that you must follow. So I wanted to run through some sort of cases with you and just sort of talk about them. The first is around a transfer of care, and those transfers, specifically the most vulnerable transfer that I've seen so far are the direct admissions coming from one hospital into another, specifically when there's more than an hour transport time in between, because a lot of patient condition can change in that regard. So here's the example. An 82-year-old male with shortness of breath presented to a local emergency department. He was diagnosed with pneumonia and COPD exacerbation, treated with steroids and antibiotics, yet remained tachypnic. They called the tertiary care hospitalist requesting a direct admission, verifying that the respiratory rate was indeed 94%, and he had 4 hours later, the patient arrived to the receiving facility. So he had a respiratory rate of 30, an O2 sat at 94%, There's nothing here about what his blood pressure was, pulse was, the amount of oxygen he was giving. This is the only information that was passed along. And 4 hours later, he arrives, and he's found to have a pulse of 132, a blood pressure of 94 systolic with a wide pulse pressure, a respiratory rate of 34. He's on 6 liters per nasal cannula with 90% O2 sat. 2 hours pass while the RN's paging the MD. Direct admission, bypassed the ER, went straight to a general care ward because that's where the hospitalist had accepted them to. The resident was delayed because they were doing an H&P on yet another patient. By the time that the resident arrived, the vital signs had deteriorated to the point where the first thing the resident had to do was call the RRT. Now, in this particular case, the patient already met RRT criteria while they were waiting for the resident to come. And we've had several cases like this. Now, on this next slide, the exact same story is on the left. And using the categories of opportunities for improvement that we use in the safety learning system, for any of you who are sitting at your computer, this is an active question, so I would love to have you type in the question or comment section, which of these opportunity for improvement categories do you think actually potentially occurred during this 82-year-old man's journey from one hospital to the next and then to his RRT criteria? Go ahead and just freely type any of them that you think may have been opportunities. Agreed. Communication, delayed rescue of deteriorating patient, lots of communication issues. Diagnostic, transitions, absolutely. Almost all of them with the exception of procedural. I agree with all of you completely. These are the sorts of things that we're trying to capture in our Safety Learning System Collaborative, or SLS Collaborative, is to get to this level. And then under each of these categories are many other subcategories. Because to fix what this man experienced, there are many smaller things that we need to be able to get our hands on. So let's go through another case where we have a vulnerable system or process and do the same thing. So this is related, this is the end of our summary when we actually went through this recognition process in our own facility and got down to what the actual contributing factors were to people going to the wrong place in the hospital. And what we recognized were in those direct admissions, patient had a 62-fold increased risk of death if we put them in the wrong place when they first got to our facility, like that 82-year-old gentleman. And that has led to many projects for us around recognizing and rescuing deteriorating patients and appropriately calling our RRT teams. Next one, I'm specifically going to call this problem hospital-acquired sepsis. Now, why do I think hospital-acquired sepsis, once they're already in the house, not when they're in the ED, is relevant specifically? A lot of the work that you've seen both in the talks in Sepsis 1 and Sepsis 2, they were both emergency room physicians, a lot of the work has happened in the ED and the ICU. Much less has actually happened out in the general care wards, other than maybe a couple order sets and maybe some mandatory lactate ordering, but certainly not the extent of engineering has gone into those systems. And that plays out in Mayo Clinic's O to E mortality rate in Rochester, that our O to E for acquired sepsis is twice as high as our O to E for sepsis on arrival. And so here's an example of somebody who was already in-house, came in and had an elective total abdominal hysterectomy, developed acute kidney injury, urinary retention, abdominal distension, significant pain. Things got worse, developed an episode of paroxysmal atrial fibrillation. That spontaneously subsided. They stopped her opioids because of her distension in her abdomen. On the next day, she became hypotensive, diaphoretic, and nauseated. The RT called, but there was no blood pressure when they arrived. A code was called, more than an hour of resuscitative efforts, and on autopsy, they found an abdomen filled with pus and a nick in the small bowel. So there's 3 to 4 solid days where she had no antibiotics and no fluid boluses. So with this same patient, looking at those main categories, same thing. What do you suspect may have happened all the holes in the Swiss cheese, so to speak, that may have led to her death. Diagnostic, absolutely. All except maybe end of life, good. Delayed rescue. Yep, agreed. All categories. Very rarely have we found that there's just one opportunity for improvement as we're applying our safety learning system method to doing chart reviews. There's so many things that can happen to our patients, and it isn't just one of them that usually occurs. When we see one occurs that has a significant bad impact, very often those patients are very elderly or very frail, and any one thing can tip them over the edge. But for our younger patients, like the 59-year-old that we just talked about, multiple can actually, I mean, she survived for 4 days in spite of us. In the next case, I want to get into what Dr. Clements referred to as not only is there badness, but when there's badness, is there infection? So SIRS implies badness, unless it's me climbing 3 flights of stairs, which I guess could be badness too because I'm so out of shape. But anyway, the SIRS could be any of these other things. So let's take a look at this patient. He's a 77-year-old man who presented to the emergency department after a fall in the shower, kind of banged up. He had not been feeling well for 2 days, had a loss of appetite, vague lower abdominal discomfort. His vital signs are as noted there. Lactate was 5.1 when he came in. He was diagnosed with a UTI. Sepsis bundle was followed to a T. He improved, and he went home without any chronic disabilities. Okay, that's one version. There's an equally possible second version. He had not been feeling well for 2 days, loss of appetite, vague abdominal lower discomfort, same vital signs and same laboratory findings, found to have a UTI, sepsis bundle followed, but he became more delirious. His lactate level increased. He required pressors to sustain his blood pressure. Eventually, the family declined intubation, and he died. Now, what I want to point out about this UTI, he had bacteria on a gram stain, but only 5 to 10 white blood cells in his urine microscopy. He had mesenteric ischemia. And I've seen this happen a couple times, both with sepsis and acute coronary syndrome getting messed up, mesenteric ischemia and sepsis. Multiple different things can present as SIRS. And so that presents, again, that diagnostic challenge to us when we know we have to act early for any of these, but specifically for sepsis, we have to act early. But if we act early, we may cut our investigations or our differential diagnosis short, end up with some confirmation bias, and then miss the diagnosis that's already there. I look at all of those that we just discussed, all of those opportunity for improvement buckets as system failures. None of us come to work to have somebody be in pain, to miss a diagnosis of sepsis, to have someone suffering when they die, to ordering the wrong test or starting the wrong antibiotic. That's not why we come to work in the morning, and all of us are very well intentioned. So with that as the backdrop, when these things recurrently happen to a bunch of people who are doing the best they physically and mentally are capable of doing, something's not supporting our providers that's allowing them to actually make mistakes. So how do we protect our patients and our providers? So here's some quality improvement initiatives that I found, a couple from outside Mayo and a couple from within Mayo. So this was an initiative that was done to improve early sepsis care in the emergency department. They had a 3-tiered intervention. It was a nurse-driven screening tool and management protocol to identify and initiate early treatment, a computer-assisted screening algorithm that generated a sepsis alert pop-up in the medical record, and an automated suggested sepsis-specific ordering set for initial workup and resuscitation, and antibiotic selection with goal-directed therapy. What they found is in their results, their bundle compliance went from 28% to 71%, and their mortality rate dropped from 13.3% to 9.3%. Now, the latter was not statistically significant, But with time, that sort of rate and that drop would absolutely be. But the first one was. And this was done at the University of Washington Medical Center. It was published in the BMJ of Quality and Safety, and they are one of the Safety Learning System collaborative participants. Another project that was done was a quality improvement initiative targeting sepsis. They started with a survey to define the problem, and I applaud this to try to actually understand what's going on before you start throwing fixes at things. So they surveyed their residents and nurses with clinical vignettes regarding the recognition of sepsis. 56% of the 136 residents got it right, and 17% of the 280 nurses got it right. I did not get far enough into the detail with the degree of experience of the nurses, because when we studied recognition of our nurses of deteriorating patients, it was over 90% when agreeing with the docs, with a critical care physician, when the nurse had 5 or more years of experience. It was less than 30% when the nurses had less than 1 year of experience. So what I don't know is how biased their 17% is towards years of experience with residents. So they developed a robust educational program using Sepsis, which I haven't seen, I'm very interested in looking at. It's an online game from the Stanford University that both nurses and doctors can play. Their intervention, they use Muse as a trigger instead of SIRS, again, a very nonspecific trigger, but a trigger. The nursing, they engage nursing aides, and they had them start charting vital signs, enter them in real time into the EHR, because there's often a delay when a nurse has a choice between treating the patient and putting information into the EHR. Very often, they'll do the right thing and take care of the patient before taking care of the computer. So if they have somebody else entering things in real time, that's really helpful. And they can receive prompts to retake the vitals if they're abnormal, because you don't want a set of erroneously taken vital signs in someone's EHR if it's going to trigger a standardized response. And their standardized response included decision support tools that included a pre-populated medical order panel with all the patient's base information and based on their diagnosis, their antibiotics, and those sorts of things, which made it very easy for the physicians to actually do the right thing. We don't have results. This was done at the University Hospital in Salt Lake City. We don't have results yet, but they anticipated that they could save 50 lives and $1 million per year. And one of my interests is following up with them at this point. It's been about a year since they started to see what their findings have been. So what about Mayo? What have we agreed to do? And Dr. Casey Clement spoke with this. Again, I mentioned we talked about our guiding principles. So what we've agreed is that we are going to bundle, and we're going to bundle the following things. Lactate needs to be measured within 1 hour before or after a blood culture. Blood culture needs to be drawn before antibiotics. Antibiotics need to be administered within 1 hour of severe sepsis or septic shock onset, and fluid boluses for hypotension or lactate greater than 4. So those are that's our bundle that we're using. And this is where Dr. Arnold put our approach in comparing it to Sepsis 3 and CMS. So you can say we're not doing either. We decided we wanted to act quickly when a patient appeared sick and determine if they have an infection and sort out the differential before just assuming that they have sepsis. Our action arm, or our extrinsic arm, is that there's an obtrusive alarm that shows up in our emergency department. So this is piloted and is being done in our emergency department. It requires interaction. So if the patient meets the appropriate criteria, they get a roadblock. They cannot order anything. They cannot do anything unless in their EHR unless they actually respond to this siren, which actually sort of flashes on their screen. And the only way they can proceed is to fill out what they think the patient's diagnosis is. And those two sides, they have to answer to both sides. In addition, there's a clinical decision support ordering tool, and on the floor we have something very similar to this. It doesn't help us with any of these other laboratory studies. What it does do is tell us, okay, you think they have sepsis, you think they have an infection, and you think it's UTIs. Here's your antibiotics based on, and it sorts out age, creatinine clearance, all the allergies, all those certain things, so that we can choose the appropriate antibiotic for appropriate likely microbe and patients' other comorbidities. So that was in the emergency room. On the medical floors and surgical floors, general care wards, we made a conscious decision not to do sepsis screening. We decided to screen for deteriorating patients, which would include sepsis patients, because we found that our number 2 and number 3 to later misdiagnosis included respiratory failure and exsanguination. We wanted to be able to capture those as well, and they get tachycardic and tachypnic and hypoxic and everything else right along with it. So we knew that some of the vital sign parameters would be similar enough that we wanted to be able to capture them. So we developed a new score that we use, the Mayo Clinic Early Warning Score, to identify any type of deteriorating patient, and then develop this tiered, time-limited escalation of expertise at the bedside. So our response to a potentially deteriorating patient is not an order set for tests or an order set for antibiotics or anything on the floor, because the differential is yet to be completely sorted out. It requires a physician to go to the bedside and actually evaluate the patient and then use their own clinical judgment and experience to take the next step. With this, we've actually increased the speed with which we're able to deliver antibiotics and IV fluids to almost an hour per patient, so finding the golden hour, so to speak. What's in common between these 4 different examples of things going after sepsis is that they're all proactive and as opposed to reactive. And they all have an afferent limb and an efferent limb. So they have a prediction of who's going to be at risk, some scores, some risk models, some combination of vital signs, and a follow-up action needed to prevent the deterioration, the progression of sepsis, treat the sepsis, whatever it happens to be. So whatever you do when you're developing, just finding something that tells you the patient's at risk doesn't really change anything. If it does change something, it's because you relied on the heroism of your providers to actually respond to that, or to actually see that it's happened so they can respond to it and then do, quote, do the right thing. We've decided that heroism sort of needs to be pulled out of the care of patients to the point where, yeah, we'll all go above and beyond. But on those days where we're so fatigued or sleep deprived, where we just need support so we can actually get through the day and think clearly, we need that standardized response that will ultimately move the needle on improving care. I'm now going to switch gears from pulling everything together and giving you some examples of the quality improvement initiatives and talk about the safety learning system, the international collaborative that has been generated. And this came out of all of our mortality work and now is expanded beyond mortality work into learning from the living and not just the dead. Our main thing that we did when we started developing our mortality review work, or now our safety learning system work about 15 years ago, is that we moved away from peer review, the concept of peer review. We wanted to understand the processes and systems that actually allowed our providers to make mistakes. And when I compare and contrast that to peer review, we identified that in peer review, the problems identified, it's reviewed and discussed by a group of peers who may or may not include the individuals involved. And then the individual contributes to the conversations, responds to the conversation, or is just notified. I remember just getting letters when I was at a different hospital in Michigan. I didn't even know anything was coming, and all of a sudden I would get this letter. In the safety learning system, by contrast, the reason that the patient is reviewed, their care is reviewed, is not because they've been reported as having an event, or not because somebody's gone to the voluntary reporting system, or someone's complained about a doc's behavior, or something along those lines. The patient is reviewed as a member of the cohort strictly because they're a member of a cohort of interest. So it could be mortalities, it could be sepsis. We've got teams looking just at septic patients, whether they died or not. It could be high-class cases. It could be long length of stay. It could be RRTs, bounce backs to the ICU, you name it. It could be any cohort of interest. Readmissions, that's one we're working on because that's a needle we still haven't been able to move the traditional quality improvement approaches that we use. So we're going after it by doing a little bit of an engineering dig into things and understanding what's going on. So those cases are reviewed and discussed by a group of multidisciplinary, multi-specialty peers, nurses and doctors of all types and stripes. And they identify opportunities for improvement through consensus, and then that learning is shared broadly so that we can all learn. So that's the principal difference between a peer review method and what we're doing in hospitals with the safety learning system. Our goal is to identify opportunities for improvement, not fault. And so what is an opportunity for improvement? This is where one of my high horses comes in. At Mayo, our credos, our vision, our values, and everything revolves around the needs of the patient coming first. And it was very well worded by William Mayo over 100 years ago, that the best interest of the patient is the only interest to be considered. So we use that when we're looking at these charts and reviewing them. So it's not about whether or not the doctor picked vancomycin instead of Zosyn. It's not about whether or not he called it community-acquired pneumonia versus hospital-acquired pneumonia. It's not about whether or not there was a nick in the small bowel during the surgery. It is absolutely about the fact that the patient had no check on their vital signs for 12 consecutive hours after coming out of the operating room, or they had an average pain score of 8 when in the last 24 hours of their life, or the antibiotics were delayed 8 hours because somebody thought it was given in the ER, but it wasn't because the transport whisked the patient up to the floor, and then the floor thought the antibiotics were given, and the ED thought there was, but the patient never got them. It's not about those things. Those are all systems and process-related things. And so we're looking for anything that we're willing to say that if we watched our family member go through that scenario that's playing out in the chart that we're reviewing, if we were very comfortable watching that scenario play out and not wanting a colleague to come in and help our loved one, then there's probably not an opportunity for improvement. However, if we're not comfortable with what's playing out, respiratory rate of 32 for 12 consecutive hours with 4 of them being in an ambulance. If we're not comfortable with that for our own loved ones, then we shouldn't be comfortable with it for your patients or our patients in our hospital. And so that's the level set that we use when we're going through these charts. So mortality cohorts are the ones that are most commonly being looked at right now because people are still thinking about mortality review, although we're trying to work with people to move into learning from the living as well, or from a cohort that you're having difficulty with, like sepsis or readmission. Some live, some die, but there's stuff that goes on in their care. So in this particular Pareto diagram, it demonstrates that the top 7 things in this are all opportunities of omission, not commission, the biggest bucket being the end-of-life opportunities. And the biggest bucket under that is for the delayed recognition and rescue of deteriorating patients, which is number 4 in this bucket, so well over 100 cases. The number 1 in our collaborative is sepsis, no surprise, followed by pulmonary diagnoses and then neurologic diagnoses. So this isn't a problem just at your hospital. This is a problem at hospitals, at least in 2 different countries, across all 4 corners in the middle of our country. And that gives us some common language once we dive even a little bit deeper to understand why the later misdiagnosis occurred. So when we did that next level dive, these were the top 7 contributing factors to the later misdiagnosis category, specifically around sepsis. Diagnostic accuracy, so mesenteric ischemia instead of sepsis, or acute coronary syndrome instead of sepsis, or appropriateness of test ordering, gradual decline in patient condition, level of provider experience, delay in escalation of care, timely follow-up on labs, and the intensity of treatment not being adequate for the severity of the patient's illness. Now let's look at the sepsis cohort. There's a couple hospitals doing the sepsis cohort. Let's take a look at those. In those, the number 1 opportunity for improvement were treatment opportunities, followed by end-of-life care. So what were the treatment opportunities? The generic evaluation and monitoring, so vital signs being recorded regularly, patient follow-up after giving fluids or antibiotics, appropriate floor that the patient's on, appropriate level of clinical expertise being provided to the patients, all the evaluation and monitoring things that we do every day in the hospital. The second one were treatment issues, and then the third, communication. So those general issues, and these numbers are very small, but appropriate level of specialist knowledge, so that was in our top 7 list for mortalities. Escalating to a higher level of expertise, that was in our list as well. And timely follow-up and acting upon ordered labs and tests, that was present as well. So these are very small numbers. There's only 100 patients in this. But if you stop and think that 3% of the patients in your hospital may not have the appropriate level of specialist knowledge, that's intriguing. what the system that we use for the safety learning system also allows you to drill several other directions. So in this particular case, we asked the question, okay, so where are these treatment issues being identified? And the biggest bulk was in telemetry. And that's probably, outside of your ICUs and your general care wards, one of the smaller areas in your hospital. So if I were queen for a day in this hospital and we were working on sepsis, I would want a multidisciplinary group to deep dive into some telemetry-based charts, find some patterns, and see what we could do from a problem-solving perspective to improve performance on the telemetry units. That keeps the scope small, it keeps the problem focused, and allows you to actually try something before you scale. So it creates a very actionable insight with a lot of definition around it. So you all know how strongly I feel about the iceberg, or many of you have heard me speak, that the largest reason we started doing the mortality review is because we were frustrated with the fact that all we were learning was what was at the tip of the iceberg. Those were our voluntarily reported things, our sentinel events, etc. But what we found is that 80% of the opportunities to decrease suffering actually were under the water. They were not visible. They were not being reported. That has played out in spades at every single hospital participating in the collaborative, whether you're in Australia or the U.S. or Canada right now. So my question to you is, what's hiding under the water in your healthcare system? Our safety learning system through Q3 2017 is growing. The stars here represent healthcare systems, each with multiple hospitals that are participating. So my question to you, or my proposition to you, is to add another star for us or for yourself and join our Safety Learning System Collaborative. We would love to partner with you and share the learnings from all of our sites so that we can all grow faster and shave 10 years off the learning by learning from all the experiences of the systems and from Mayo Clinic who's gone before. And with that, I close my comments. Thank you.
Many thanks, Jeanne. Fantastic.
I'm sorry, I forgot. I had one more slide, Dr. Denham.
Go ahead.
So here's the details in terms of joining the collaborative. It allows you to identify similar actionable insights, identify your opportunities, increase your physician and nurse engagement, because our method is to use the nurses and the physicians by having practicing nurses and doctors together talking about the exact same dirty laundry in your hospital. The team culture builds, as does your safety culture. And through the system, you're able to lead up and influence and inspire your leadership to make the change you need to save the lives of your patients in your hospital. And one of the biggest issues that we're able to prioritize and right-size quality improvement initiatives, just like I mentioned with that telemetry floor around the treatment issues. You don't have to do the whole hospital. You can just start on that telemetry floor, use a tailored amount of resources, and actually learn before you scale. If anyone signs up after this webinar following between now and the end of December, we'll offer 20% off the annual membership in 2018. When it takes a while, 2-3 months, to get through all of the IRBs and the related data use agreements and those sorts of things. So once all that's done, you would, on an estimate, be starting in Q1 2018 to actually begin going through cases with us. And finally, we can't play the video, but this is just on the tongue-in-cheek side, or a little cheeky side. If anyone has not had the chance to watch this video created at Kern Medical about Sepsis, it is funny and drives some very strong points.
Great, and we'll put the link on your page, and then any other resources. I'd like to ask you, Jeanne, to give us the application forms and documentation, the latest documentation for those that want to join the collaborative, and we'll post them on the page on safetyleaders.org. So if you go to safetyleaders.org or click on webinars and go to Jeanne's webinar for this month, we'll post PDFs and whatever form, Word, whatever documentation, Jeanne, that you would like to have posted so that those that want to consider the collaboratives can do so. And since we'll move on to some questions, and I think there's some good ones here in the Q&A section, but we'll also put the link for this funny video there so that people can click on the link and then go watch the video. But my question is what is the cost of joining the? What is the? It's so reasonable. I think it's kind of crazy. So I'd like you to be able to tell us, what is the cost, and then with that discount. And then the second question is, what would be the typical steps that somebody that's watching this webinar might undertake to do that? Who do they typically need to meet with? And you know the process because you've had to be through it so many times with the other collaborators. Could you cost, and then what are the action steps people need to take?
So the cost is $22,500 per year, and the 20% discount for the first year would be $18,000 for anybody that's currently on this webinar and references it in an email when send it to me. So basically, it's emailing me. There's a group of contracts and everything that my colleague and I, Lacey Hart, send out to you. We work through with your contracting folks, and at the same time, we do a current state analysis of your existing processes through your hospital, so you can see in your system how different your hospitals are currently performing. That helps us understand what sort of change management you might have to go through to get into this level of detail in the review process. We have 2 on-site training sessions where I come on-site and do meetings with leadership as well as reviewer training in groups. We have webinars that we use to support and online training, both by demand and then open office hours, so to speak, where we help support your reviewers so that they can actually do a review in a very timely fashion. The whole key that we use is to try to help people get through a screening process in a review in 15 to 20 minutes, and then spend more time on the cases that actually need the time. So that's sort of a summation.
Great.
We have quarterly meetings, learn from each other, and we're starting to develop quality improvement initiatives together.
Fantastic. So I'm going to draw people's attention. Kyle, would you please put the survey up? We're going to just survey you regarding these topics as an audience. Please respond, and then we're going to go through the questions that are in the Q&A section. And while I go through that, Jeanne, if you wouldn't mind just skimming over the Q&A questions, there's some good ones, while I cover the survey and conduct the survey so that you can be prepared, and then you can pick the ones you want to answer first and go from there. So the national survey questions are first, I am interested in more detail regarding sepsis. This has been such an overwhelmingly supported topic that although we've done a series of 3 programs, we don't mind doing another one if you want a deeper dive, but we've got to hear the specifics that you want to have covered that may not have been covered in the 3 that we've given on sepsis. So that if you want more and you want more drill down detail, for instance, others that have initiated the sepsis programs, or perhaps some of Jeanne's collaborators that have really focused on sepsis and can talk about their practical implementation and where they got started and what they worked on, please give that a 10. Tell us, we really want that if you do, and if you'd like it, but not, then a lesser number. But we don't want to tire you out with the topic, but we want to make sure to serve this audience. And we have as many as 80,000 people through 3,100 hospitals, and typically we might send out, 25,000 invitations to have. We had 600 pre-registrants today, so there are others that might be out there. And so if you have a feeling that this is important, please let us know. And the second question is a free text question. So in the free text question, put in what you would like to be covered, because that really guides our speakers on the topics that you would like to have covered or questions that you might have. And we review them. We'll review them today. We analyze them and we get back to the speakers, and we'll get back with Jeanne on this. The second question is, I'm interested in a webinar addressing patient safety issues regarding triage and emergency department. And as Jeanne had mentioned, I think on earlier webinars, when they looked at their triage process, the wrongful death or the or lives saved when they really worked on that at Mayo were pretty amazing. And we have a number of really, really top-flight emergency department physicians that are part of our network and speaker network. So we'd like to know if you'd like to have triage. Second topic, maybe more broadly, is the emergency department. And we're hearing from our emergency department docs that there's an amazing disconnect on return precautions. They'll see a patient, see a family, they get through this acute period, but lots of the processes and communication break down on return precautions. What should you do if something doesn't get better? Who should you see? When do you call back? What do you do if? Is an enormous breakdown. And also having the patient's history and the medications at the time of an emergency visit. And then the free text question is specific triage and emergency department questions anywhere along the continuum from bystander care to triage, pre-hospital care to the full circuit through the emergency department. Anything that you believe would be important for us to cover for you. Then the third, and this is the last questions, Jeanne, are regarding EHR. As I addressed in my preamble prior to Jeanne speaking, we addressed the ECRI topics, and two very hot topics. One are this continued issue regarding EHR, and it may be CPOE and related to medication management or more broadly. And then second, which overlaps with the EHR, is the misdiagnosis, delayed diagnosis issue, which is an enormous problem, and now the press and malpractice attorneys and everyone are starting to catch on to this being a real tip of the under the waterline on the iceberg that Jeanne had shown. So EHR-related safety issues that could include but not be limited to diagnostic issues, recognition of deteriorating patients, errors, anything that may be going on in the electronic healthcare record and any aspect of it, and then specific related safety issues related to the EHR and the risk areas. We know there's been an enormous problem with the EHR vendors being willing to share the areas where they've got risks, and in fact, it was quite a fiasco to try to get them to do that. So I want to come back to Jeanne on the questions. Jeanne, have you had a chance to look at some of the questions that have been asked?
Can you hear me okay?
Yeah, go
All
ahead.
Right. So I'm looking at one from Charlene Kelly Co. about broadcasting broadly. We do two different things in Rochester. One, we create, after each monthly multidisciplinary, multi-specialty case discussion, we create a case report, basically a story of the patient's journey. Absent any nurses and physicians' names, absent any words called like should or could have or things along those lines, that just objectively report out the patient's experience, and at the bottom summarize what our opportunities could have been: palliative care team, assistance in the hospitalization, or recognition of the deteriorating patient, or something along those lines. Very objectively written. The second thing that we do is on a quarterly basis, we create a report that has all of our Pareto diagrams, statistical process control charts, all of those sorts of things in it. And that goes out broadly to all of our leadership, practice leadership, quality leadership, safety leadership, nursing leadership. It goes everywhere we can get our hands on it, and goes up and down within our institution, including out to our sister hospitals in our affiliated hospitals. And then we, parallel with that, do a report, a verbal report to our quality and hospital practice leadership, and go through what we saw as new trends and recommendations. So this is the leading up. This is the inspiring and influencing our leaders to say, we see a new trend in aspiration postoperatively, or recognition that a deteriorating patient is still our number one problem after 10 years, or whatever it happens to be. And then we make definitive recommendations about they need to charge a team and provide the resources. Because one of the things that we've learned very, very quickly, that if you ask the group that's doing the reviews to start doing the fixing, they don't have time to do the reviews anymore. So we report directly to our leadership so that they can charge the appropriate people to do the fixing. So those are two different things. I work very carefully with each hospital to help them develop the way that makes the most sense for them. So this is one of those principles of you need to share this information as broadly as possible. Like our cases are all reviewed at M&M. So our M&M conference now in Department of Medicine, cases come from this process. Emergency department, same thing. So depending on how you spread it, that whatever you do will make most sense within your structure, your culture, and your organization. And so the principle is just to disseminate and allow everybody else to learn as much as possible. We're still doing our CMS subtraction. There's three different timings that we can order on the lactate specifically. And there's two different types of lactate. If we're just curious, we can order a lactate, and it can be ordered routine, which means it might come back in an hour, or we can order a priority one, which will come back in about a half hour, or a stat, which will come back in about 15 minutes. And if we want specifically a sepsis lactate, then we do that, and then it automatically gets reordered every 3 hours, or on the third hour, so that we don't have to remember to do that. If you join after this seminar, it's good from here from when you sign the contract. So whenever that, just get it to bring it back. And then, will these slides be made available to us? Yep, everything's going to be there. I have not heard anything specifically about transferring from acute to PAC settings. I know that we've got multiple processes, and if you're in a team that works on that a lot, so if you are interested, then I can put you in contact with that person.
Jeanne, I'm going to jump in real quick. Kyle, if people are having a problem with the polling, if you could just double check. I'm having a problem just clearing it, so I'm just going to mention that real quick. Jeanne, go ahead and continue, and I've got a couple questions when you're done.
I think I've finished all of them.
Great. So, so this challenge of getting this sold internally, can you walk us through what the typical process is?
My understanding, Lacey does a lot of this work with each of the hospitals. There's a number of documents that end up involving legal, supply chain, and research, and we have all of them pre-written, so they just need to be edited to fit your institution, and find the contacts to do that. Any requirements that any institution has had regarding the participation or sharing the data or whatever, we've been able to agree with anything. So nobody has ever had to decline participation because of bureaucracy. We've been able to meet every institution's needs, including the other thing that comes with it, and I'm sorry to mention, is the software that we've developed to learn from the living, not just the dead. So it includes all types of reviews, mortality reviews, readmission reviews, peer review, RRTs, whatever it happens to be. So we have that availability, so whoever's in the cohort has free access to that for the year of their contract, and then every year they renew.
So, Jeanne, the payoff for this kind of program in terms of financial payoff, because I know a lot of our organizations they're constantly under this financial pressure, and if you don't win the CFO and the COO vote, we call it green light, you can't green light the project, no matter how great it may be. And many organizations may not adhere to their vision statement as much as I know Mayo does, because I've been there and seen it in action. But this obsession with financial returns, I think can you share with us the non-confidential things that you've shared with me over time, where people are seeing a reduction in wrongful death, and just without naming any organizations, just the fact that there is a definite financial argument that can be made.
So one organization that I know that's been doing it for a long time has had a real reduction in their wrongful death suits, although their legal department wouldn't give them the details, of course. The others that we've seen, one of the collaborative sites stopped calling their palliative care team palliative care and now calls it advanced illness management, and put an AIM nurse in their ER and dropped their mortality rate by 20% in 3 months because patients weren't dying in the hospital anymore. They were going back to the nursing home to home hospice, or maybe for a short stint in the hospital with the goal on getting to hospice. So the cost reduction in that and those lengths of stay is tremendous. Another hospital I know of, they had a pattern of every patient who came in automatically was defaulted to full code. Nobody had conversations until there was a need. As a result, they ended up with, gosh, I reviewed their cases, I bet at least 30% of their deaths were over the age of 80 or older, some 90, some 100, and were intubated and in the hospital for days before conversation was actually had around goals of care. So they're working on that, and their potential financial gain is out of this world in terms of what they could do, and not to mention improving their, decreasing the suffering that their patients are experiencing. So those are just a couple that have come to the top of my head.
Great. So if folks want to, I'm going to turn to Jenny here in just a minute, but if folks would like to download the information regarding the collaborative, they will be able to do so from the page, Jeanne. So any of the latest documents that you'd like to have be made available, I think we know some in Texas now that are going to step closer to the line to do so. Can you describe how frequently does that group get to talk with each other? One of the things that we found, now we've been doing this 34 years, is the importance of the networking, talking to another organization like themselves. So are there lots of the new ones that are newbies that are kind of in the pipeline that they can collaborate with as they begin this journey?
Yeah, we have all collaborative conference calls every 3 months for those who are in the first year. The second year and on, we're doing every 6 months, depending on, unless they want more, we've got a new project going, in which case we'll spin off. So, for instance, we're authoring a number of papers right now. So there's multiple multidisciplinary small groups working together on a paper. The other thing is that we meet once a year at the IHI meeting, and I buy everybody dinner, and we get together and just meet each other face to face and get a chance to talk and have a good meal.
Fantastic. So you had the chance now to review sepsis. We've had two great speakers. If we were to do another focused area from your standpoint, and I know I'm catching you just surprising with this question, but Jeanne, what haven't we covered that we could cover that you think might be important? Because you're out there and you're such a great antenna that receives these messages that are out there, because the organizations that are really starting to identify this problem are really starting to address it. If we were to embark on one more webinar of value in that area, what do you think we should cover?
I would love to hear everybody else's opinion on that.
Good. Well, for me, and I'm hearing from folks that I'm talking to people that have actually implemented a program from scratch, how they did it, who they talked to, how they got champions involved, what the early wins were, the surprises and the speed bumps are the things that I know that I'm hearing as I talk to folks. We're 23 minutes after the hour. Jenny, would you like to ask any questions of Dr. Huddleston or make a comment, because you're an official reactor on this for us?
Thank you, Dr. Denham. I think it was a great presentation by Dr. Huddleston. I think, omissions is a really huge problem for the consumer of healthcare world that I'm a part of. We have had many, many losses throughout the years where failure to rescue was the real culprit. I think this innovative, great new work that's being done right now is going to save so many lives, and I'm just so thankful and touched by the innovation and the creativity of this brand new level of patient safety that's going to revolutionize everything and just resurrect the beginning stages when we first learned how many people are actually passing due to medical errors every year. My question, Dr. Huddleston, I do have a question, is have you engaged patients and families at all in any of these procedures where you're working? And I was wondering if you have been utilizing the patient-family voice or incorporating that into any of the work that you're doing.
I have a group of patients and family members that I work with at Mayo Clinic that participated in sort of the generation of understanding what the issues were and the opportunities were as we made our list, because the list of the things that we looked for, the opportunities around treatment and diagnosis and delayed recognition and deterioration, every single one of those things, subcategories that I didn't get into completely, represents at least 5 people who had that problem at Mayo Clinic. So we did not just sit around like a bunch of arrogant academicians and create a trigger list. What we did is that list grew. Initially there was no list. That list grew after there were at least 5 people who had that. And so we let our patients tell us what we needed to be following and what we needed to be fixing. In terms of having patients and families actively involved, not a single organization that I'm working with yet has gone there, except for one in Michigan.
Well, fantastic. We know that we would certainly love to hear. We'd love to hear from you, about that. Well, I think what we'll do is we'll be wrapping up this webinar today. I wanted to draw everyone's attention to this critical issue of opioid overdose, protection of your caregivers, and especially the healthcare networks where you've got patients that are streaming in from out in the community. We're going to take a full-on what we call medical fusion approach with the first responders. We're working together with the security guards, with the police departments at the University of Texas Health Science and the whole Health Science Center. There are at Texas Medical Center. There are 160,000 people that drive in every day, and so this is a great laboratory, and we're working with MD Anderson, on this, and so we'll have. I think some good coursework after September in focusing on the opioid overdoses, the Stop the Bleed programs, the use of tourniquets, pressure dressings, packing the wound, this national program that was started during the Obama administration, and the Trump administration has continued to support it with Homeland Security. So this whole MedTac program will continue to be tackling and bring those back to you, but it's very likely that we may, if our audience wants it, Jeanne, we'll do another sepsis webinar. If it looks like we've covered enough for now, we'll move to the opioid and the EHR and misdiagnosis area. So we're so grateful, Jeanne, to you for your work. I think your work really is the next generation of patient safety. I think it's probably as important as what happened in 1999 when the IOM report came out, and Don Berwick wonderfully led and mentored all of us in this, with Carol Harridan and Roger Resar there with you at the Mayo, and it's just been, I think we're getting a whole new shot in the arm by the work that you've done, and we want to thank you, Jeanne, for being such a tireless champion and to carry the flag sometimes when it was really difficult. And so thank you for doing that, and thank you, Jenny, for always being there for us and the voice of the patient. So, Jeanne, are there any last words you'd like to say? And if not, then we'll have Jennifer close us.
No, I just want to thank everybody that's currently working in the collaborative. I just got a beautiful note from somebody who's on the webinar and part of the collaborative, a huge champion. So, and Patty Atkins, who's actually spoken on TMAT as well. So thanks to everybody who believes in this work, because you're making a difference.
Well, God bless you, and thank you. I know you're a person of faith, and that's what's carrying you on, and so we really, really appreciate it. Jenny, would you please close us and have the last words? The patients and families will have the last word, and then, well, thank you for being with us this summer. It's been a great summer of webinars, and September should be a really great one. So, Jenny, would you please close us?
Dr. Huddleston, and thank you so much. I wanted to thank you very, very much for engaging patients and families and getting their opinions before you went forth in this work. I think that's the key to changing things and making healthcare safer for everybody in our country. So I think we're well on our way to a renaissance of patient safety, and I have to largely give you the credit for it, because you're a pioneer, and I just can't thank you enough. With regard to the webinar, it was wonderful, and again, I can't thank everyone for being here enough on behalf of patients and families and our team, our patient family activist team. And just as I said earlier, please spread the word, invite your colleagues to future webinars, share this particular webinar with others, please, because this is something that many, many don't know anything about at this point in time, and I think the more that you share it, the more people are going to understand, and the better things will be in the future. So God bless everyone. Thank you so much, and have a great rest of your summer. Dr. Denham?
Thank you, and we'll ask our speakers to stay on. We do a quick process improvement loop to see what we can do better next time, and we thank all of you, and have a great month.